Como moderadores do primeiro bloco, convido ao palco Dr. Ricardo de Almeida Neves, Doutora Tatiana Souto, Latest Thinking and Treatments for Dry Eye é o assunto a ser discutido agora. Convidamos ao palco Dr. Koray Gümüş.
Bom dia. Unfortunately, these are the only two words, and I will go on my presentation in English. So before starting my presentation, I would like to thank the team of the Johnson & Johnson, and special thank the Yannis from my neighbor. So I'm very happy to be here and to be a part of this such a great organization. I would like to thank you. Thank you for all your coming. And this is my financial interest, but I see here in Portuguese, so can I change this in English? So, you know, as we know that the dry eye disease is a very important disease and it's very common in the population. And we can see some different types of cases and some of them are very easy, some of them are very challenging, and we know that as a physician, as a clinician or as a scientist, our main goal is, you know, treating these patients and we want to be successful in our management. So there are some factors that affect our success in the management. So we have to know that. That's why I'm here, and I want to talk which factors can affect our success. One of them, we have to eliminate the risk factors. We have to define all the predisposing factors in the dry eye disease, and the education and the education and the time. You know, we have to spend enough time for our patients are the key factors for the success. And when we categorize the treatment, the management of the dry eye, the taking environmental measures is very important. I always talk to my patients in terms of this kind of environmental measures like the air condition, because we know that nowadays all the people use the excessive use of air condition, and the tablet or the computer use is getting higher. So it's very important to remove or minimize the use of these kind of predisposing factors. The other thing is taking the behavioral measures is very important. I really pay attention to all of my patients, the lid hygiene, the warm compress, and blinking habits also very important, especially against the computer. Blinking habits is very important, and the drinking water, the consumption of the water is extremely important to be successful in the treatment of our dry eye patients. Of course, we have some medical agents, some of them to lubricate, to moisturize the ocular surface. Some of them are anti-inflammation. And of course, the fish oil and autologous serum we can increase, and I will talk about very briefly in this presentation. And the last one is in severe cases and challenging cases, we can also switch the treatment modality to punctal occlusion or the contact lenses, especially scleral lenses. I will talk about in the later my presentation. And sometimes we need to transplant the amniotic membrane or the salivary gland transplantation in very severe cases. So, the main purpose of our treatment is to maintain the homeostasis, to provide enough tear production and the higher quality tears, because it's not enough to provide enough tears. We have to provide more qualified, more higher quality tears. So this is so important. And the last one is to repair the ocular surface, the problem, the ocular surface integrity. And overall, our aim is, you know, we want to try to increase the quality of life in business, in the social life, and we want to make our dry eye patients happy. I think it's not still working, but it doesn't matter. I am trying to look at the small screen. No, everyone knows that the DIVS report, so it really helps us in the management of our treatment and in our management of the dry eye disease. Basically, this report summarizes the management of the therapeutic options for treating the dry eye patients. And we know that before starting our medications, we have to decide the grading. We have to grade our patients in terms of some clinical findings, such as ocular symptoms, visual symptoms, the conjunctival injection, which is a sign of ocular inflammation. And the conjunctival staining, corneal staining are very important parameters and findings for grading. And the corneal and tear signs, for example, if you have the filamentary changes on the corneal surface, it really helps us to grade the patients. And lid or meibomian glands, the health of and its products also is very important. We have to evaluate it. And the tear breakup time and the Schirmer score also help us to grade our patients. And when we use all of these parameters, these clinical findings, we try to decide the dry eye severity level of our patients. And then, using these severity levels, thanks for arranging, and with this severity level, we decide how to treat our dry eye disease. But honestly, you can see you have to start these medications with the stage 1, stage 2. But I'm sure maybe in your clinical practice, it's not the rule. You can modify this. I also modified in my clinical practice, but it's a guideline for us to determine the clinical severity level and what kind of medications I can start in the management of dry eye. The patient education is so important. So what should we educate? What should be teach our patients? The nature and the importance of the disease is so important, and the possible consequences and its chronicity is very important. It's not an acute disease. It's a chronic disease like the diabetes mellitus or hypertension. We have to talk about and we have to give examples like that. And the elimination of the predisposing factors, the drugs and excessive computer and the AC, we have to talk about this. And we have to talk about the behavioral measures, and we have to talk about the treatment posology and their details, their posology and their duration and their possible adverse events. We have to inform the patients very specifically in terms of all these parameters. So my first question, we always discuss this question in Turkey and in other European meetings. How much time do you spend for the patient with dry eye disease? If you suspect dry eye disease, how much time? Less than 5 minutes, 5 to 10 minutes, 10 to 15 minutes, 15 to 20 minutes, more than 20 minutes? Yes, I really wonder what changes from Turkey and Europe and here, because let's see. Can we see the result or? Oh, okay, we have time. Sorry. So we always discuss with my colleagues because I will see the results. I really, with curiosity. Okay. Wow, you are better than our colleagues in Turkey. Congratulations, really. Because unfortunately, my colleagues in Turkey choose maybe A, maybe B, but not C. But as I can see here, someone in this room spent more than 20 minutes. Can I see these people? I really congratulate, because it really needs time to assess the people. The dry eye patients. It's very crucial. Otherwise, you cannot be successful in the treatment of the dry eye disease. And the tear supplementation and the stabilization, the control of inflammation of lacrimal glands and ocular surface are the mainstay of the therapy in dry eye disease. And the tear supplementation, you know, all of us use the artificial tears because to lubricate and help maintain the moisture on the ocular surface. We know that it doesn't mimic the composition of the human tears, but the recent improvements increase the efficacy. For example, we can use some combinations for example, I don't know you have, but the 3 halos and the plus hyaluronic acid or the some other combinations. Lipid-containing artificial tears so important because the most of the dry eye cases have the MGD, so this is so important. And a recent improvement, some artificial tears may exist enhanced with flaxseed. So I'm sure that the numbers of the new products will increase in later. So I want to talk you the neurostimulation. I don't know any of you heard about this modality. This is pretty new, and TrueTear is the name of the brand, and is the first and only neurostimulation device for the treatment of dry eye disease, and is already FDA approved to safely stimulate the nerves that supply the lacrimal functional unit, which is very important for the ocular surface health. There are few studies so far, and I also want to share my experience with this neurostimulation because I work in 2 studies in United States for the FDA procedure. So I would like to share my experience how neurostimulation will contribute to our management. One study is about the clinical study. This study is included 40 patients and with mild to severe dry eye disease, and enrolled subjects were provided with a nasal stimulation instrument and instructed to use it at home 4 times daily, or if you need, you can use it more. And the follow-up assessments were conducted up to almost 6 months. It's a very long duration. It's not so acute evaluation. And the endpoints are the tear production, quantified by Schirmer scores, the corneal and conjunctival staining, and the visional scale, and the OST scores. When we look at the results, the Schirmer score, the difference between the stimulated and the unstimulated Schirmer scores, as you can see here, for each eye was statistically significant at all time periods, all time points. So it means that really neurostimulation works and stimulates the tears production. When you look at the symptoms at each study visit, the mean changes from baseline for each of the 8 VAS categories were statistically significant, so you can also remove the ocular symptoms when you use this device. It's a good thing. And when we switch that, I think I skip. No, okay, that's it. So when we concluded for this study that the neurostimulation of the nasolacrimal pathway is a safe and effective means of increasing tear production and reducing symptoms of dry eye in patients of the dry eye disease. And I want to show you our current paper, and it has already been published in the American Journal of Ophthalmology. The 5 normal and 10 dry eye patients were enrolled in this study. This is a This is a 3-visit study consisting of 1 screening visit and the other separate randomized mask and intranasal tear neurostimulation. So what's the reason of this? So it's okay. So as you can see in these pictures, this one is, you can put the instrument like that. This is the intranasal stimulations example, and this is the sham application. This is the extranasal application for the placebo application. So when and our aim is to investigate the effects of the neurostimulation on conjunctival goblet cell degranulation. So this is the unique one. This is the first one we investigate the effects of this neurostimulation on the goblet cells. And the 2 meniscus height and 2 meniscus area also were measured by using the anterior segment OCT before and after the application. We also do the impression cytology for in the right eye for PET staining, and in the left eye for the MUC5AC, which is a common mucin of the goblet cells. So I want to share this. Our main point in the study was the ratio of the degranulated to non-degranulated goblet cells was measured as a marker of secretion. I want to show you this picture. This is PET staining and this is MUC5AC staining. Look, you can see how the goblet cells can explore and the granules of the mucin. So you can see very easily under the microscope. It is very amazing. And I want to show the results. A statistically significant increase in T meniscus high and T meniscus area after intranasal application was observed both in the normal and in dry eye patients. And you can see in the Sjogren patient, this is almost double after the intranasal neurostimulation. And what about the ratio, the goblet cell degranulation? You can see that this bar are after intranasal. This is, inferior bulbar, and this is temporal bulbar, and you can see how it increases the degranulation after the intranasal neurostimulation. And I want to show you one example. So this is very demonstrative. You can see here. Look, this in the left side, all goblet cells seem to be in a non-degranulated form with intact boundaries and packaged MAC5AC stained mucous granules inside the cells. But conversely, in comparison, in the right picture, most of the goblet cells show the degranulation pattern with disruption of the cellular morphology and exocytosis of MAC5AC stained mucous granules and mucin outside the cells. So this is extranasal application in the same patient, and this is the intranasal application. So how you can see how it changed the goblet cell degranulation with this new neurostimulation treatment modality. So we can conclude that these findings indicate that the intranasal tear neurostimulation can trigger conjunctival goblet cell mucin secretion, which may be a unique feature of this therapy compared to other currently available treatments. So when we talk about anti-inflammatory treatment, which is a very important part of our management, the control of inflammation of the lacrimal glands and the ocular surface is extremely important. You can see the list here. I will talk about later. And at this point, I want to ask you, which severity level do you start, honestly, in your clinical practice an anti-inflammatory treatment in dry eye disease? The grade 1, grade 2, grade 3, grade 4, or I don't start anti-inflammatory treatment in patients with dry eye disease? Let's see what happened. Here we go. Oh, this is a little bit different when we compare the results in Turkey, because normally we started with the stage 2. But nowadays, I don't know why, but it's a little bit coming earlier. Some of my colleagues start very earlier on, even the patient with stage 1. But you started, most of the cases here started, the 50% is with the stage 3. We can discuss later. And interestingly, 10% of our colleagues do not use anti-inflammation. Maybe we can discuss later. And which anti-inflammatory modality is your first choice? The topical steroids, topical cyclocyprin A, topical steroids plus cyclocyprin A, and autologous serum eye drops, or topical tacrolimus if you have. Here we go. The topical steroids alone is the most one. Normally, yes. In my clinical practice, I always start with the topical cyclocyprin A plus steroids for the acute effect, because the effect of the cyclocyprin A starts after 1 month. That's why I always combine with the steroids. But, of course, all these options are okay. But we can discuss which patients need the steroids or which ones do not need the steroids. We can discuss later. So the topical cyclocyprin A, we are so lucky in Turkey because we have been using this agent, I think, since 2008. We know that the cyclocyprin A inhibits the T cells proliferation and it prevents the release of some pro-inflammatory cytokines from the cells, and therefore the decrease the epithelial apoptosis It increases the conjunctival goblet cell density, and it restores the barrier function of the corneal epithelium, and it decreases the conjunctival T cell density. These are so important. This is one of my case, 24 years old male. He had a blepharitis and related dry eye disease, and he only used artificial tears before coming to my clinic, and no improvement was obtained because just artificial tears he used. He had a severe foreign body sensation and hyperemia and burning. As you can see, the OST score is very high, and you can see how it's very, especially in the lower part of the cornea, the corneal staining is very severe. And we also started to warm compress and lid hygiene very carefully twice daily, and a topical cyclocypronate twice daily, and topical preservative-free dexamethasone for a month, and a preservative-free artificial tears. I generally prefer the vitamin A pomade during the bedtime. It really helps people to wake up much better. And you can see how dramatically change after 4 years of the topical cyclocyprin A use. The patient's changes from this picture, and now it's almost normal. And this is the new one, the Lifidegras ophthalmic solution. It seems to be a very safe option for treating patients with dry eye disease. It's already been approved by FDA in the United States. It's a novel topical integrin antagonist. I don't want to give some details about this, but there are no enough clinical trials about this. I'm sure that when we have this molecule on our market, we will have some experience, but this is an alternative maybe for the future. Oral tetracycline and the topical microlids are so important because they have the antibacterial, anti-inflammatory and anti-angiogenic effect. They also inhibit the synthesis of matrix metalloproteinases, which is so important. And it's very effective in the acne rosacea and the posterior blepharitis, and it can also help the skin lesions in our patients. This is one of the most agent I always prefer, especially in MGD or posterior blepharitis. And autologous serum eye drops includes albumin and numerous growth factors and anti-inflammatory factors. That's why it acts as a biological tear substitute and replacing the essential growth factors to maintain ocular surface health. And it's very effective in Sjogren's syndrome or Stevens-Johnson syndrome. Some severe cases, it really helps us. But the problem is several factors limit its use. I don't know you have experience with the autologous serum, but in Turkey we really use very much. But the sterilization problem, it limits the use. The risk of viral transmission, the frequent need for blood draws, and the difficult to drink preparation, storage, and the cost are the limitations for this nice agent. The second case is 41 years old female. She underwent a LASIK surgery 1 year ago, and the OST score is high, and you can see the corneal staining, especially in the central part of the cornea. We also started topical cyclocyprin A and a topical logepreninol for a month, and we switched the artificials to hyaluronic acid because which I believe that it's more efficient than the other artificial tears. And I also add the autologous serum 20%. And for a month, and I also prescribed the fish oil in Turkey, and the patient, as you can see, after 4 months it's getting better, but after 6 months it's almost normal. But it's still, the patient also has still take the medications. And the other one in challenging cases, the punctal plugs, the contact lenses, especially scleral lens. I have lots of experience about scleral lenses, especially in Stevens-Johnson syndrome, in graft versus host disease. I always try the scleral lenses as a very good option, and it really helps this kind of patients. Botulinum toxin injection, we had a paper about this. It may really help to the patients with the filamentary keratitis, especially blepharospasm, so you can release the tonicity of the lids, so it really helps us. Secretagogues, in my clinical practice, I don't really use the secretagogues. And the surgeries, I never do the salivary gland transplantation, but sometimes, especially the neurotrophic keratitis, I sometimes have to use the amniotic membrane transplantation and tersorrhaphy. We can do it. So what are the take-home messages of my presentation? I want to summarize this. The management of dry eye disease is very complex and requires a very careful and detailed assessment. This is so important. The prognosis depends on how successfully you manage the inflammation in dry eye. I really pay attention to the inflammation, the role of inflammation in the management, and the patient education and sharing necessary information about dry eye and its management increases efficacy. That's why we have to spend enough time to educate and to discuss all the options about the management of the dry eye disease. The last time is okay, the spending enough time is definitely mandatory, and I would like to thank you and obrigado. I was there, okay.
Para falar sobre conditions related to contact lens wear, in other words, understanding reality, convidamos ao palco Dr. Arleta Waszczkowska.
Bom dia. First, I would like to thank you so much for the invitation. It's great to be here, and I thank you for a very warm welcome. And I would tell you that similar congress is held every year in Warsaw, in Poland, and I invite you to Poland. What are we going to deal with today? There are some guiding thoughts regarding this lecture. Do not about complications. Everyone has patients with complications, it's normal, but learn to think about conditions related with contact lens usage. Learn to recognize them in a proper way. Learn the best possibilities to proceeding. I have no slides. Okay. I will start with a question to you. What do you mean by healthy eyes? The first proposition, eyes are quiet, or no pathologies observed during eye examination, or patient doesn't feel any discomfort, or they allow good vision. Let's start vote, shall we? Okay, thank you. Of course, each of given answers are only partially correct, and all merged in one sentence represent healthy eye area. There are no simple questions, as we have many of answers. Tear film, cornea, conjunctiva forming functionally and structurally ocular surface exhibit a specific immune response. Cornea, thanks to its vascularity and very low presence of antigen cells, presenting cells, and it has a status, a privileged tissue. Contact lens usage is correlated with complications and states related with contact lenses. We'll proceed to the most common, stopping by the most serious. Corneal epithelium is the first line of defense against the pathogens, and everyone knows that healthy, proper tear film means healthy epithelium. But Okay, but each person's tear film can become unstable due to environmental changing condition, use of makeup or fatigue. The proper evaporation of tears water amounts to 35% of the total amount of tear film, but in the first stages of the meibomian gland dysfunction, we have an evaporation above 50%. And another question for you. Which of the following statements about ocular surface disorders is true? Is it that they continue the contraindication to wear rigid contact lenses? Second one, they always require soft contact lenses wear, or they require the full diagnostics and the cause identification before contact lenses fitting, or they are the main reason for discomfort during contact lenses wear. Can we start? Oh, yeah. Okay, of course, the correct answer is number 3, but what does the full diagnostic mean? Is it the anterior segment OCT, osmolarity, or microbial identifications? In this short lecture, I will try to tell you that the most important you have in our offices. It includes interview with the patients and full slit lamp examination. And think about this problem. What's the main factor responsible for complications performance during contact lenses wear? Is it the material or water content in contact lens material, contact lens thickness, fitting, wear and replacement schedule, or tear film stability? Let's vote, please. Okay, thank you. All the answers are correct, but the most important factor is missing, which is not following to recommendation of the specialists and lack of hygiene. 50% of contact lenses users have complications, up to 21% of them within every year. And the patients with contact lens related problems go quite frequently to other specialists instead of ophthalmologists, and the proportion is almost 50-50. How do you think, what is the average time between alarming symptoms appear and contact lens wearers' visit to specialists? Is it 5, 12, 24 hours, or 3 or 6 days? Please vote now. I'm sorry, it's terrible, but the average time is above 6 days. It appears that most cases of complications fail to establish clear risk factors, but we can see that the main causes of complications are sleeping with the lenses and long wearing. The first problem which I want to discuss is allergy, because it affects 20% of population. And we can see that the younger generation is suffering from allergy. For all kinds of allergy, the symptoms are very similar. For the contact lens user means following: decline the comfort of life, reduce time of wearing lenses, itching, dryness, foreign body sensation, and sometimes resign of the lenses. What should we do? When we have allergy interview, we should very carefully examine tarsal conjunctiva, because atopia plays an important role in GPC, in contact lens related giant papillary conjunctivitis, and papillary reaction greater than 0.3 millimeters is always considered abnormal. In giant papillary conjunctivitis, the size of papillars are more than 1 millimeter. GPC occurs in 15% of soft contact lenses users and in 5% in rigid glass permeable contact lens users. In the pathology of the GPC, we have a mechanical irritation, conjunctival traumas at every blink, 20,000 times per day. And another factor is allergic factors, which means that we have a deposit on the contact lens surface contained with mucin, cells, bacteria, and proteins. What should we do? We can treat allergy obviously, but we should change the time of wearing lenses for shorter. Sometimes we can observe immune reaction which provoke allergic or toxic reaction to preservatives. It may appear after months or years, but usually we can see immediate reaction after putting on the lens into the eye. What she would do, what we should do. We should change the liquid curve for more compatible with lenses or without preservatives, or change the lens for one-day disposable lens. And another problem are deposits on the lenses. These deposits can not only, as I said, induce GPC, but they are also excellent breeding ground for bacteria. We can offer our patients following instructions: education of them, washing and rubbing the lens, reduce of makeup, or paying attention to take products, makeup products that they do not get into tear film. Or the third way, and in my opinion the best way, is change lenses for one-day lenses. Corneal epitheliopathy, it causes 68% of all complications. And it's usually the answer for extended contact lens wear during the day, sleeping with the lenses, incorrect technique of putting on or taking out the lenses, incorrect contact lens fitting, or allergy. It's usually asymptomatic and discovered during the fluorescing staining. Treatment. I recommend moisturizing drops. Antibiotics are very controversial. I have never given antibiotics without inflammatory reaction, but I recommend to change the lens for the best index of oxygen transmissibility. Other frequently occurring diseases, sector hyperemia, the most frequently appearing at 4 and 8 o'clock, and it's related to area of corneal inflammation, as usually response to hypersensitivity or to multipurpose solution or peripheral infiltrate. Corneal vascularization is usually the response to hypoxia, which might occur with a tight-fitting lens, but it may be also answer to inflammatory conditions or autoimmune diseases, or allergy for preservatives, or it may be answer for injury when the patient wearing damaged lens. Acute coronary inflammatory reaction accompanied by nighttime sleep with the lens. The patient waking up with severe pain, redness, photophobia. Characteristic is that it's usually one-sided. Only one is affected. At characteristic, we have no corneal damage. Superior limbic keratoconjunctivitis is a chronic and recurrent inflammation of the eyelid and bulbar conjunctiva and cornea from 10 to 2 o'clock. It can last from several months to several years. It's usually bilateral but asymmetric, and it's also an answer to preservatives. Inflammatory cell accumulation in the subepithelial part in the cornea is an immune response to staphylococcal exotoxins, deposit on the lenses, preservatives, hypoxia or contamination under the lens. And contact lens related peripheral ulcer is caused by Staphylococcus aureus or epidermidis. The patient colonizes this bacteria on the eyelashes and eyelids. It usually heals itself, but always leaves a scar. We should treat it like microbial keratitis, but I recommend in this case give steroid drops to minimize immunological reaction and minimize a scar. And I would like to introduce the differences between microbial keratitis and peripheral ulcer, because there are two different diseases, two different prognoses for the vision, and two different approaches to treatment. Microbial keratitis is situated centrally or paracentrally with significant pain, while peripheral ulcer is usually peripherally, but it's usually asymptomatic or gives a little pain. Usually resolves spontaneously, or short break in wearing lenses is good enough for improvement. Regarding the treatment of microbial keratitis, I have never ever recommended steroid drops for it because it making condition worse. The frequency of microbial keratitis is about 10%, and the most frequent pathogen is gram-negative Pseudomonas aeruginosa, later gram-positive Staphylococcus and Streptococcus. But we should remember that contact lens users, especially in the extended replacement schedule, can have multibacterial infections. The lack of hygiene is causes of almost 50% of bacterial inflammation. And in extended replacement schedule, the risk infection amounts to 0.21%, and the daily wearing allows to reduce the risk to 0.04%. It's believed that fungal coronary infections are much less common than bacterials, and they are about 5–10% of all corneal inflammation. But the prevalence of fungal keratitis has increased significantly in recent years, especially contact lens users and people undergoing chronic corticosteroid therapy. The fungal keratitis has worse prognosis for the vision and requires a long polytherapy. And the last one, amiabic keratitis. It's a rare disease, but most often, up to 70% of all cases of amoebic corneal ulcer is seen in patients with contact lenses. Acanthamoeba is the most common protozoa in soil, dust, sweet or salt water, and the serological studies has shown that most of population has anti-acanthamoeba antibodies in peripheral blood and tear film, which confirm the frequently contact with this pathogen. We should remember about the education of the patient. We should remind that they shouldn't wash the containers with water, and they should put on the lenses with dry hands. Treatment is very complex and long. It takes even 1 year, and I would like to say that in my experience, the first procedure which I perform apart from drops, apart from treatment, is corneal debridement, which helps to take away the protozoa before they penetrating deeper layer of cornea. Summary. Patients who follow recommendations of hygiene suffer less from complications, and in most cases of complications, discontinuation is good enough to improvement. Summarizing, a quick reaction to discomfort is crucial, specialist is essential, and the key is the best quality products. Choosing the one-day lenses is the best way to prevent the complications. Thank you for your attention. Obrigada.
Economia da saúde, oportunidades e desafios no Brasil. É o próximo assunto. Convidamos ao palco Dr. Silvio Junqueira.
Bom dia a todos. Vou ajustar melhor aqui. Bom, eu vou falar um ponto que é um pouco distinto, né, do que vocês estão acostumados. Esse daqui. Vou falar de um tema de economia da saúde. Eu vou me apresentar primeiro. Eu sou diretor da área de economia da saúde da América Latina, aqui na Johnson & Johnson Medical Devices, que compreende todas as nossas áreas cirúrgicas, né? Desde a Eticon, que vocês devem conhecer nossos fios de sutura, a parte de ortopedia, a nossa parte de cardiologia. A Vision Care, ela, no futuro agora a Vision, né, não faz parte do que nós cuidamos de economia da saúde. Porém, eu conversando com o pessoal, eles pediram para vir aqui falar um pouco sobre economia da saúde e tentar passar um pouco para vocês, como oftalmo, o que nós fazemos e tentar trazer esse assunto aqui em pauta hoje. Então, vamos falar um pouco do conceito, né? O que é isso, Silvio, quando você fala que você trabalha com economia da saúde e acesso ao mercado? Pensando, a economia da saúde, ela é essencialmente o estudo de escolhas, né, de como que a gente vai alocar recurso. Então, se a gente pensar um tempo atrás, tudo era reembolsado. Pensem na prática de vocês como oftalmo. No passado era muito fácil, aqueles que são mais antigos, conseguir reembolso para qualquer procedimento dentro do convênio ou até mesmo no SUS. Hoje em dia, foram criadas barreiras. E por que foram criadas barreiras? Os custos na saúde foram subindo. Com esses custos subindo, métodos de avaliação para incorporação de tecnologias em saúde foram criados, principalmente devido aos medicamentos oncológicos. É só pensar que medicamentos oncológicos eles foram introduzidos, eles conseguiram elevar a expectativa de vida do nosso paciente, mas no passado eles custavam muito caro por um pouco benefício que eles traziam. Por exemplo, a gente tinha aqui medicamentos que custavam um alto valor traziam 30% mais de sobrevida ao paciente, mas 30% se refletia em 3 meses. Por isso foi criada a área de economia da saúde, para poder trazer como fazer uma avaliação do que realmente vale a pena incorporar. Então, quais são os principais pontos que a nossa área trabalha? A gente identifica essas barreiras de acesso, acaba trabalhando com os não clínicos, né? O meu trabalho é muito mais com o pagador, com o governo, do que realmente com a área médica. Nós também empoderamos médicos para que eles tentem reembolso de muitos dos procedimentos. Trabalhamos com modelos econômicos, fazemos estratégias de acesso para os nossos produtos e temos propostas de valor com base em evidência clínica e econômica. E por que a gente fala isso, né? Vamos pensar no mundo de medical devices. Quando a gente fala em inovação em medical device, é um pouco diferente da farma. Na farma, a gente trabalha muito com esse sentido, inovação disruptiva. Vamos lembrar no passado que a gente tinha telefone celular e o que a gente tem hoje. Você tinha um startup e você migrou para o smartphone. Isso é uma inovação disruptiva. Hoje, o que nós menos fazemos é falar no celular. Usamos ele para tudo, menos para falar. Isso pode ser considerado inovação disruptiva. Um medicamento, quando ele vem, depois de 10 anos que ele é trabalhado, ele tem que ser uma inovação disruptiva. Senão, você não tem isso como incorporado no sistema. Em compensação, no mundo de medical devices, é diferente. Cada pinça que nós lançamos para uma cirurgia, cada grampeador, ele vai ter uma inovação incremental. É como se a gente falasse do iPhone 1, 2, 5, 6, 7. Quando você compara o 1 com o 7, tem uma diferença. Mas, ano a ano, foi criada uma inovação incremental. E por que isso é importante em economia da saúde? Porque quando alguém vai pagar por isso, alguém fica pensando, poxa, então por que eu vou pagar por uma inovação incremental, sendo que o benefício não é tão claro? Então, a gente acaba trabalhando com vários conceitos. Uma outra comparação que eu gosto de fazer sempre é de avião. A gente tem 3 tipos de avião aqui. Um avião dos anos 50, um avião da pior companhia aérea do mundo, que é a da Coreia do Norte, e um Airbus, que é o mais moderno que tem. Todos eles vão voar. E todos eles vão te levar de um ponto a outro. A diferença aqui é quando a gente fala realmente entre a tecnologia mais antiga e a tecnologia mais nova. A tecnologia mais antiga vai te levar igual. Mas quando você compara com ela mais nova, você vai ter uma diferença no que você vai estar fazendo. E é assim que tem que ser avaliado o setor de medical devices. Vamos falar um pouco da área técnica. Eu não quero pegar muito isso com vocês, porque senão vai ficar meio chata a minha apresentação. Vamos lá. Quando a gente fala em custo e efetividade, vamos pensar em 2 matrizes, uma de custo e outra de efetividade. A de custo, quanto mais caro for o produto e ele tiver pouca efetividade, você não vai usar quando você tem um comparador, que é mais barato e que ele tem melhor efetividade. Em compensação, se você tem esse que é mais efetivo e ainda mais barato, você não tem dúvida de que você vai incorporar. Porém, no mundo, existe um outro ponto. A maioria das tecnologias, elas estão nesses 2 quadrantes que estão em cinza agora, em que você tem, ou ele é mais barato e ele é pior, ou ele é melhor e é mais caro. E como que isso é avaliado? Você tem que traçar um limiar. Até quanto eu quero pagar para poder usar algo melhor? Por que isso? Imagina que vocês querem ir daqui ao Rio de Janeiro. Vocês têm 2 alternativas, avião e ônibus. Tá? E o desfecho que vocês querem encontrar, a efetividade é tempo. Então, vocês vão chegar mais rapidamente de avião do que de ônibus, porém, vocês têm que pagar mais caro. Qual que é o limiar que vocês colocam, que vocês estão dispostos a pagar mais caro para chegar num tempo mais curto? Correto? Deu para entender? E quanto que vocês falam, poxa, não, isso ficou muito mais barato, eu posso esperar. Essa é o padrão de custo-efetividade. E aonde cai a maioria das avaliações em saúde. Tá bom? Quando você traça esse limiar, abaixo dele, você vai acabar tendo essa questão e vai poder estar usando esse tipo de produto. E quando a gente fala isso no mundo de médico, indústria, pagador e hospital, né? A gente está falando de novas tecnologias. Então, vamos pensar no médico. Ele busca ser inovador, ele busca o melhor resultado para o paciente, e muitas das vezes eles não são formados na área de economia ou de administração. Isso acarreta o quê? Ele quer dar o melhor tratamento, mas ele acaba sendo bloqueado por quem paga, dependendo de quem está pagando. A indústria, ela também quer ser inovadora, ela também quer dar o melhor para o paciente, mas dependendo do preço que ela está no mercado, o procedimento dela vai ser incorporado ou não. Aonde ela tem mais chance do procedimento ou do produto dela ser incorporado? Quando ele impacta em desfecho. Impactar em desfecho é fundamental para quando a gente está falando nos produtos da indústria. Passando. E o paciente e o pagador? Bom, aqui hoje eu estou falando para um público muito interessante, que é muito diferente do que eu estou acostumado. Porque o pagador aqui, quando a gente fala em lentes de contato, é o próprio paciente. É muito diferente de quando eu vou falar sobre uma pinça de energia, ou quando eu vou falar sobre um grampeador, ou uma prótese de joelho, porque no final, o usuário final não é quem paga, né? A gente tem como um pai que te banca. Quando a gente fala entre paciente e pagador, o que a gente está tentando falar é que o pagador ele tenta entregar o melhor ao menor custo, mas nem sempre ele olha o desfecho. E o paciente ele quer o melhor resultado no tratamento, ele busca qualidade de vida e conforto. Quando a gente junta todos esses pontos do mercado, hoje o que a gente tem falado muito, principalmente no setor cirúrgico de medical devices, é a medicina baseada em valor. Quando que a gente vai estar olhando para desfecho? Por quê? Porque valor é diferente de custo. O que eu tenho falado muito e que a gente tem vários projetos hoje em dia ocorrendo, principalmente em hospitais na área cirúrgica em São Paulo, também tenho na Colômbia e tem em outros lugares. O valor é quando você tem o desfecho e experiência do paciente dividido pelos custos diretos e indiretos. O que ocorre? Quando você escolhe um produto ou um tratamento, às vezes mais barato, isso pode impactar no desfecho do paciente. Mas nem sempre também o mais caro é o que vai dar o melhor desfecho. Para isso tem que ser avaliado. E hoje, cada vez mais é importante medir desfecho. Por quê? Porque o que ocorre hoje em dia, e que já está mudando nos Estados Unidos, e eu tenho trabalhado aqui na América Latina e tenho visto essa mudança, é que os nossos hospitais eles não são medidos por desfechos. Se eu faço uma colecistectomia no Einstein ou no Oswaldo Cruz, hoje, antes de eu entrar lá, eu não sei qual que eu vou ter o melhor resultado clínico. Eu posso ter uma percepção de hotelaria, eu posso ter uma percepção de qualidade, mas ninguém me fala em quanto tempo eu vou ficar internado, ninguém me fala, de acordo com o meu perfil, qual é a minha chance de ter infecção. Isso a gente tem mudado essa conversa. Vocês fiquem calmos que eu vou chegar no mundo da oftalmologia para falar sobre isso, o quanto que eu consegui ligar e o que a gente tem trabalhado bastante com isso. Por quê? Qual que é o cenário no mercado de saúde? A gente tem a cobertura cada vez mais sendo bloqueada, uma grande variação na prática médica, envelhecimento da população, demanda crescente de novas tecnologias e pressão no orçamento. Isso daí se traduz tudo em desafio. O que acontece? Criam-se barreiras e você tem menos escolhas, porque o pessoal está olhando o custo e não está olhando o valor. Ok? E como que a gente pode mudar esse tipo de trabalho? A gente tem que olhar a avaliação de perfil de risco, medir os desfechos e os seus custos e adotar tecnologia que impacta o desfecho. Eu falo muito isso para várias tecnologias e vários procedimentos. O que eu consegui ligar um pouco hoje no mundo da oftalmologia, principalmente no mundo da lente, que é o nosso assunto de hoje, é o seguinte. A colega da Polônia acabou de apresentar que 50% dos pacientes que usam lentes têm algum tipo de complicação. Ou seja, o que é valor para esse pagador? O pagador, no caso, é o paciente, é quando ele se livra da complicação. Certo? Olhando estudos aqui, que o pessoal me passou, quais são os fatores de risco que vocês encontram para ter um problema no uso de lente? Higiene inadequada do estojo, troca de estojo pouco frequente, tipo de solução multiuso utilizada, dormir com lentes. São todos fatores de riscos que são eliminados, às vezes, por a adoção de uma tecnologia que pode impactar em desfecho, que é a tecnologia de descarte diário. Ou seja, quando você muda, né, em relação a um tratamento que você elimina alguns fatores de risco e, além disso, traz algum caso, esse caso desse estudo, por exemplo, em que pacientes que usam lentes de descarte diário têm 12,5% menos chance de ter um evento infiltrativo corneano, com lente de troca, quando comparado com lente de troca programado, é o típico caso de uma tecnologia que impacta em desfecho e a gente está criando valor. Esse foi o tipo de ligação que eu consegui fazer quando a gente está falando entre valor e a gente está falando entre tratamento, que é o que nós temos trabalhado hoje com a economia da saúde em relação aos procedimentos de medical devices e como que eu penso que se pode ser trabalhado em termos de lentes de contato. Em resumo, né? Quando a gente fala um pouco de economia da saúde e valor em lentes de contato de descarte diário, as complicações, como elas são frequentes, elas vão ser, assim que diminuídas, elas trazem valor ao paciente e ao pagador, que no caso de vocês se confundem na mesma pessoa, né? O limiar que o paciente pretende gastar na lente de descarte diário é algo importante. Lembrem-se daquele quadrinho, né? Quanto que é o custo, quanto que é a efetividade. No caso da lente de contato também tem uma diferença, né? Muita gente gosta de usar lente de contato, não só por uma melhor visão, mas também por um fato, algumas vezes estético, ou outros de liberdade, para fazer esportes, ou algumas outras atividades do dia a dia. E como eu já falei, pacientes, no caso de lente de contato, são pagadores e, portanto, serão os mais interessados em ouvir sobre os desfechos, em ouvir sobre o valor de que elas podem trazer para eles. Com isso, eu deixo a minha apresentação e me junto com o pessoal dali. Muito obrigado.
Iniciaremos agora a primeira sessão de perguntas e respostas para as sessões deste primeiro bloco, a ser conduzida por nossos moderadores. Lembramos que durante todo o tempo, até mesmo durante as apresentações, você pode fazer suas perguntas através do número WhatsApp que está nas telas, 95809-1433. Esse é o número correto para enviar suas perguntas. Em seguida, teremos uma votação eletrônica para avaliar o conteúdo das apresentações. Com a palavra, os moderadores.
Bom dia a todos. É uma satisfação participar do terceiro Simpósio Científico Internacional Acville. Queria agradecer à comissão organizadora e vamos iniciar a sessão de perguntas. Pergunta para o Dr. Koray. Como você trata pacientes após cirurgia refrativa e após transplante de córnea?
Thanks for asking. These are very challenging cases, especially after the PK, the penetrating keratoplasty, and after the LASIK surgery. Sometimes we always know that the LASIK may cause the adverse events in the cornea in terms of the dry eye disease, but I also have some very bad cases after, they are referred to me from the private medicine. After the PRK also, we can face some dry eye disease cases. So in these cases, I definitely start the topical cyclocypline A. And sometimes, normally in normal cases, I started this topical steroid, preferably preservative-free, and not for a month. In these cases, I a little bit I can increase the duration of the steroids, maybe two months, and tapering it. And autologous serum, as I said, and in these cases, it really works, and it really helps us. And the post-PKK, and also I really like the fish oils and autologous serum, especially for the post-LASIK cases. In the refractive surgery, after the refractive surgery. And we also have coenzyme Q10 in Turkey. I don't know you have here on this market. I really know that the coenzyme Q10 eye drops really help in this kind of cases because it has different types of function. It has the anti-inflammatory function, it's an antioxidant, and it really promotes the corneal healing. That's why I definitely start the topical coenzyme
Ok,
Q10 in my cases, in these kind of cases.
Ok, thank you. E agora uma pergunta para a doutora Arleta Vazeskovska. Como você trata ceratite infecciosa? Você utiliza antibióticos fortificados e quais?
Does it work? Okay. When I have microbial keratitis, I give 2 antibiotics for a start. It's a fluoroquinolones plus tetracyclines. After microbiological assessment, I change the antibiotics for more compatible. But okay. It's my first step.
Ok, thank you. Agora uma pergunta para o Dr. Koray. Com relação ao dispositivo estimulação da glândula lacrimal. São 2 perguntas. O estímulo é feito, o estímulo é elétrico e quanto tempo pode ser usado e se pode ser usado na gravidez?
Okay, it's a good question. First of all, I don't know it can be used in pregnancy, but logically it can be because it's a very local treatment. I don't think that it will have an adverse effect for the baby or for the woman. It's an electrical stimulus. And normally when you put the instrument into your nostrils, into your nose, you have to touch the front of your nasal mucosa. And you start, there are 5 levels of the electrical stimulus, 1, 2, 3, 4, 5. I personally try before starting because I want to see how the patients feel about it. So when you stimulate your nasal mucosa, almost maybe 3 is the average level and it's tolerable. But when you increase 4 and 5, it really makes you feel uncomfortable. And it should take 3 minutes. You have to put and you have to adjust the level of the neurostimulation, the electrical level, and you have to keep it for 3 minutes. But for example, for our study, we used only once. But normally the company maybe recommended twice daily or 4 times daily. I don't know because we don't know, for example, in MGD, what happened in Sjögren's syndrome, which stage we have to use. There are lots of questions, but it seems that, especially our findings are very interesting. It has a real direct effect of the degranulation, but we don't know the chronic effect, what happened, for example, in the numbers of the goblet cells, and we don't know, but it's really promising.
Ok, thank you. Mais uma pergunta para o Dr. Koray. Comentários sobre o uso de colírios de análogos de prostaglandina e óleos secos.
You mean, I cannot understand your question.
Used from...
Sorry?
Análogos de prostaglandina.
Okay, Edwards, you answer? Yeah. Okay, I got you. So this is a very real problem because we have a very active glaucoma specialist in my university, and we have to always collaborate with him because we have lots of patients because it's a chronic disease, the glaucoma, and definitely the chronic use of the prostaglandin analogs and the other ones, not only the prostaglandin analogs, may have a very adverse effect in terms of some inflammation, and of course one of my colleagues has already published, and it also affects the lid margin, and it may also adversely affect the lid and the meibomian dysfunction. It may cause the meibomian dysfunction. So we had a practical how can I say? So when they start to anti-glaucoma drugs, they always consult us, especially in the older ages, in the middle-aged person, and we always check baseline their ocular surface, and we talk about some measures, as I mentioned in my presentation, some different, if there is no problem in the ocular surface, maybe behavioral measures and some the other measures may help the patients. But if it's older patients and if she or he has a problem with ocular surface inflammation, MGD, I definitely start medical treatment. The problem is, in these cases, the numbers of the drugs. You know, the glaucoma patients have to use maybe 3 or 4 drops, and you also add some drops. So so we have to choose our drops very carefully. And we definitely have to choose preservative-free drops. You know, it's very important. We are not so lucky in individual dry eye because the patient has to use maybe 2 or 3 drops in addition to the dry eye drops. So these patients are very challenging.
Okay, thank you. E agora uma última pergunta para o Silvio Junqueira. Pacientes em pré-operatório de catarata se preocupam muito com a qualidade da lente que vai ser colocada. Normalmente, uma afirmativa muito comum é que querem a melhor lente para o seu olho. Por que nem sempre isso ocorre nos usuários de lente de contato? Muitas vezes nós prescrevemos uma lente de contato que nós achamos que seja melhor para o paciente e aí, depois de algum tempo, ele volta e comprou uma lente mais barata em uma farmácia ou num representante, apesar de todo o empenho nosso em colocarmos o valor da saúde ocular.
Obrigado pela pergunta. Na verdade, isso daí acaba ocorrendo muito similar aos outros casos que nós vemos na saúde, né? O paciente acaba tomando a decisão de, como pagador, de olhar o custo. Justamente aquele gráfico que eu coloquei ali, ele fica parado olhando o custo, ele não olha o valor do tratamento dele. Quando que isso vai ser percebido como valor? A partir do dia que do dia que esse paciente apresentar um problema, alguma complicação, que ele tiver que voltar a utilizar óculos por um tempo, ele deixar de trabalhar, se ele for um profissional autônomo e ele deixa de ganhar dinheiro. Então, a partir do momento que ele sente a qualidade nele mesmo, ele vai ter mudança nessa atitude dele. É a mesma coisa como você colocou aí na cirurgia de catarata, né? Se a gente está pensando em colocar a melhor lente para o pós-cirúrgico e passar isso como valor para o paciente, não como custo, é a diferença que pode ser feita.
Okay, muito obrigado. Muito bem, nosso tempo para perguntas está esgotado, mas vocês podem conversar com os nossos palestrantes que estarão nas áreas comuns do evento. E agora nós vamos iniciar a votação eletrônica para a plateia para avaliarmos as apresentações.
Pode jogar o sinal na tela da apresentação.
Pode jogar a trilhazinha, pode estar.
Pode ir para a próxima pergunta. Próxima e valendo.
Agradecemos a participação de todos neste primeiro bloco. Uma salva de palmas.